I myself, Dr. Nitin Garg, would like to now invite Dr. D.N. Kapoor sir to invite our next speaker for the day, that is Dr. Rajesh sir, for his webinar on TMD and its disorders and a dental aspect of that TMD management. DN sir, I would like to request you to please welcome our chief guest for the day, Dr. Rajesh sir. Speaker for the day, Dr. Rajesh. Hello.
Now I would like to invite Dr. D.N. Kapoor sir to welcome our chief guest and speaker of the second session.
Am I audible?
Yes, sir, you are audible.
Okay. Dr. Chitre, AP Chitre is a consultant maxillofacial oral surgeon from Bombay Hospital and Medical Research and HN Hospital, Bombay. He earned his BDS in 1962 with credit and was recognized as honored and Best Student of the Year award, and also adjust Best Student Sportsman for extracurricular activities. He advanced himself for furtherance of the knowledge in surgical skill from Germany under academic exchange fellowship under renowned oral surgeon Professor Dr. E. Kruger in Bonn for 1 year between 1970 and 71. He is a fellow, had a fellowship in 1990 for study in Freiburg, West Germany. He is a recipient of, he is a former professor and head of oral maxillofacial surgery in the department in Nair Dental College and former president of the oral and maxillofacial surgery in year 1981, recipient of Outstanding Teacher Award and Lifetime Achievement Award from Association of Oral and Maxillofacial Surgery in recognition to his contribution of meritorious services and accomplishment carried in year 2012. He is a recipient of Cynodent Lifetime Achievement Award in 2010. He is a recipient of Perifashort Academy Certificate of Merit in 2011 for distinguished service. Dr. Chitre is well received as a teacher by his students and postgraduate disciples. So with these words, I welcome Dr. Chitre to this webinar.
We welcome you, Chitre sir. So now moving forward, I would like Dr. Kohli to please introduce the panelist and our speaker for the day. Over to you, sir.
Thank you. Am I audible, Dr. Nitin?
Yes, sir.
Thank you. Let me have the pleasure of introducing the first panelist. The first panelist is Dr. Pandurangan Harikrishnan. He is an MDS and an orthodontist and oral surgeon. He is an FDS RCS and a fellow of craniofacial orthodontics from Taiwan. He also holds an MBA, a PG DMLE, and a PhD. He is a craniofacial orthodontist and oral surgeon. He studied in GDC Chennai and KGMC Lucknow. He's trained and worked in reputed centers in the UK, the US, Taiwan, Saudi, and Bahrain. His special interests lie in surgical orthodontics and craniofacial deformities. He completed his PhD from Madras University and worked on developing a synthetic nanocomposite bone graft material. Currently, he is involved in teaching, clinical research, and practice, and serves on the editorial board of the International Journal of Orthodontics USA. Our speaker for the second webinar today is Again, a name who needs no introduction. It's my very proud privilege to introduce Professor Rajesh Dhiravani sir. He passed his MDS from Government Dental College and Hospital, Mumbai in oral and maxillofacial surgery in 1981. He has been the past secretary for 3 tenures and also the past president of the Association of Oral and Maxillofacial Surgeons of India. He has, to his credit, run 25 years of non-stop craniofacial, maxillofacial surgery workshops at Jabalpur Hospital, of which he is also a managing director. This hospital is the leading healthcare provider in central India and is a tertiary a referral center for patients from over 4 states. He is also the professor emeritus and director at Cynodent Dental College and Hospital. He is the executive council member of the MP Medical Science University and is amongst the very few non-American maxillofacial surgeons who have been conferred the diplomate of the American Board of Oral and Maxillofacial Surgery. He's spoken in, I guess, over 40 countries and be extensively on the domestic circuit. I would welcome sir now to present share his experience and deliver his very kind lecture. Thank you.
Thank you so much, sir, for such a wonderful introduction.
And also, I've had the kind privilege and good fortune of be working alongside sir for the last 13 years. So this is very special to introduce sir today.
So nice, sir. Thank you, sir. Thank you for the introduction. Now I would like to request Dr. Rajesh, sir, to please start the session. Dr. Rajesh, you can share your screen as well. Yes.
Am I audible?
Yes, sir. Loud enough, sir.
Thank you, Savi, for giving kind introduction. At the outset, I'd like to extend my heartfelt gratitude to Professor D.N. Kapoor, sir, who gave me this unique opportunity to share some of my experience in the management of temporomandibular joint disorders. And I'm going to stress more on the dental surgeon's perspective. When I was asked to speak on some topic in maxillofacial surgery, I thought it is the proper topic because every one of us, we come across temporomandibular joint problems day in and day out in our clinical practice. The reason being, with the stress and strains of today's busy life, everybody is tense and they try to clench their jaws, or sometimes the other parafunctional habits, or sometimes the hormonal changes, particularly in the females. These problems in my 40 years of practice, I have been observing that temporomandibular joint disorders are on increase. Excuse me. It's not forwarding. Yeah. So during our practice, when a patient comes to your clinic with pain and discomfort on one side of the face or maybe on both the sides, with limitation of the jaw movements, and sometimes the patient is complaining of having a clickle or propping sound, and then when we examine these patients, they perpetually have subtenderness on palpation, particularly in the region of muscles of mastication or maybe in the region of preauricular area. There are 4 questions they arise as a clinician in our mind, whether is it a dental pain or it's some kind of temporomandibular disorder, or sometimes it may mimic a sinus pain or maxillary sinus pain. It may be of odontogenic origin, whether it is a temporomandibular joint problem, or it is some other muscles, or maybe some idiopathic orofacial pain, or sometimes it may be migraine pain. So all these kinds of symptoms, they are intermingling, and sometimes we get confused what to do and how to diagnose this. So first of all, when we come across these problems, particularly in the area of ear or in the preauricular area, we must understand either it may be some kind of internal derangement of the temporomandibular apparatus, it may be some degenerative disease, maybe osteoarthritis, particularly in the elderly people, or sometimes it may be a myofascial pain dysfunction syndrome, which involves practically all the muscles of mastication. So once we come across these problems, proper understanding of anatomy and physiokinetics of the joint movements is a must. And at the same time, how do we examine these joints when such patients come to us? Once we come to some conclusion after examining them clinically, then we need to know what kind of imaging modality we have to ask for, whether it is a normal X-ray, an orthopantomogram, a tomogram, or maybe a CT or MRI. Once we have come to a diagnosis, our work becomes very simple. And then in such cases where the patient comes to you in acute phase, you need to give some medicinal treatment or some physiotherapy treatment for them. And then time to time, we have to follow them up. So for understanding of TM joint, first and foremost, TM joint is also known as the craniomandibular joint. It's a very typical type of joint, which is diarthrodial. In a human body, there's no other joint is like this. Like it is also called ganglionoarthrodial joint, which is a very complex joint. And if we talk about the anatomy, superiorly, it is formed by the mandibular fossa, which is a part of the squamous part of the temporal bone. Then inferiorly, it is the head of the mandibular condyle. And both these surfaces are separated by a fibrocartilaginous disc, which is called articular disc, which is attached anteriorly to the lateral pterygoid muscle and posteriorly to the retrodiscal tissue, which holds this disc in position. As I already mentioned, it is a very complex articulation, only one of its kind because of three reasons. First and foremost, it's having the two separate synovial joints, right and left side. At the same time, it has got intracapsular disc, and both the joints, they have to work simultaneously in coordination. Little discoordination on one side will affect the other joint also. Maybe one joint which is painful, at the later date, you'll find the other joint also start giving pains because of uncoordinated movements of the jaw. The old concept of biomechanics of temporomandibular joint involved only the glenoid fossa, condyle, and the articular disc. But as per the new concept, which is being given in the literature, it is not only the condyle, glenoid fossa, the articular disc, it is various ligaments like stylo and sphenomandibular ligaments and muscles of mastication, which are also involved in the smooth functioning of the temporomandibular joint and our overall masticatory apparatus. So we talk about the kinesiology of the TM joint. There are two distinct systems. One is osteokinematics and another one is the orthokinematics. Osteokinematics is the various excursion of the joints. One is the protrusion and intrusion, then the lateral excursion, depression, and elevation. These are the different excursion of our joint. Then we talk about the arthrokinematics. It is the rotational movement which occurs in the inferior joint cavity. And second is the translational movements which occurs in the superior joint cavity. If you see this is the diagrammatic representation where you will find there are various structures in between the mandibular fossa and the condyle. We have the articular disc, and then we have the oblique portion of the lateral ligament. Then once it starts moving, when the person starts opening up the mouth, the condyle moves only in the inferior partition, the inferior segment, where the patient is being able to open only 20 to 21 mm of opening. And then further, it is the superior retrodiscal lamina of the postdiscal ligaments, and a part of the lateral pterygoid muscle, which comes in force, which comes in picture, and then the patient will be able to open at least 40 to 45 millimeters of interincisal distance will be there. At the same time, you'll find that when the oblique bands of the TM joint ligament becomes tight, the translation starts. Condylar head starts to slide over the eminentia articularis, and it goes up to the inferior-most part of the eminentia and translate in coordination with the articular disc. And articular disc also moves along with the joint. And this is the diagrammatic representation. So where you see the disc is moving along with the condylar head. Articular disc is pulled forward through the superior lamina and condyle through the lamina of the lateral pterygoid. And there is a stretching of the retrodiscal tissue at this is the retrodiscal tissue, and condylar discal complex translates over the eminentia articularis. Any kind of incoordinated movements of the superior head and the inferior head of lateral pterygoid muscle will cause the incoordination of the condylar complex, and where the problem starts damaging the various structures of the TM joint. Now, when we talk about the disorders, basically it is the messy state where, because the temporomandibular disorder is not a singular description, it is the symptom complex. It's a collective term which describes a group of conditions affecting either the TM joint or the masticatory musculature or both. So we can always say it is TMD is always a multifactorial, and also it has got something to do with the psychology of the patient, stresses, strain, emotional stress, etc., which is called biopsychosocial. There are multifactorial etiological factors which are responsible for these various TM disorders. It may be a parafunctional habits like bruxism, teeth clenching, lip or cheek biting, or sitting with your hands on the chin, watching TV while you're sleeping. So your chin, it is pressed against your chest. All these habits are responsible for various kinds of TM disorders. And emotional stresses, of course, as I already mentioned, there is some role of our hormones also, which I'm going to talk about it. Then acute trauma to the jaw, maybe on one side or in the chin, is responsible for TM disorders. Trauma from hyperextension, particularly wherever, particularly the endodontics, they have lengthy sittings while treating these patients or during giving the general anesthesia, yawning, etc. General anesthesia, if the anesthetist is going to stretch your jaw too wide, then sometimes it may cause hyperextension, causing the trauma to the TMJ apparatus. And cervical trauma is also responsible for this kind of disorder. Then instability of the maxillomandibular relationship, if your occlusion is not perfect, and sometimes post-orthodontic treatment also, I have found some of the patients, they come across these disorders, laxity of the joint. Then we have this rheumatism, sometimes the rheumatic diseases, or patients, those who are suffering with this osteoarthritis of different joints, they may also suffer TM joint problems. And then very sick people, or lengthy sickness may also call for this kind of disorder. As I already mentioned, there are some adrenergic dysfunction in temporomandibular joint, which causes stress, which is also responsible for TMDs. And it is said that TMD symptoms are more prevalent in women than in male because of their hormonal disturbances, which are the major reason behind this TMD disorders. Various authors, they have classified TMJ diseases in various ways, but here I'm going to give you a clinical aspect of TM disorder. In general, it can be simply categorized into the articular or intracapsular or non-articular or extracapsular. Internal derangement may be because of the intracapsular disturbances, or sometimes these degenerative diseases are also responsible for these joint diseases. Whereas in extracapsular or non-articular disturbances may cause the myofascial pain dysfunction syndrome, where all the muscles of mastication and some facial muscles of expression may also involve in these painful conditions. But how do we differentiate between these three, myofascial pain dysfunction syndrome or internal derangement, or whether it is a degenerative disease of TMJ? So myopathies versus orthopathies can be distinguished by certain symptomology. If we talk about the myopathy, when we stretch the jaws with a passively, we will find a soft end feel, whereas in orthopathy, you'll find there's going to be a little resistance, which is called as hard end feel. Initially, in myopathy, it is painful, but with stretching or giving some muscle relaxants, this particular stretching or these myopathies, they are relieved at in an early date. But when we talk about the orthopathies, the pain increases with the time, and it is going to deteriorate further. With active mouth exercises, we can achieve more than 5 mm in MPDS, whereas there is acute mouth exercises may result in increase by not more than 5 millimeter. Particularly in myopathies, pain is similar on lateral or protrusive or excursive movement. But in arthropathy, when the bone is involved, the excursive movements are going to increase the pain. And it's very important to understand how do we examine the temporomandibular joint. First and foremost is the palpation of the TM joint. First, we have to observe the patient when the patient is opening. How much is the opening? Is there any deviation of the jaw on one side? Or sometimes you may find there is a protrusion. Patient, when they are opening, they try to open in a protrusive condition. So second is the palpation of the temporomandibular joint, where we have to palpate the joint in the preauricular area in both stationary, as well as we have to ask the patient to open and see whether the patient is eliciting any pain, or you feel any crepitus, you feel any click, or any kind of different feeling when you palpate the joint. The fingers are placed at the lateral aspect of both the joints, particularly at the lateral poles, and then in the superior poles and downwards. And also we have to take our finger on the articular eminence and ask the patient to open and close the movement, the mouth. The medial force is also then applied to record if there is any symptom, or whether patient is having pain in the static position, or the patient is having pain on opening and closing. And also on maximal opening, fingers are rotated slightly posteriorly to palpate the posterior aspect of the condyle, which is very, very important to understand the gravity of the pathology. Then the various muscles of mastication we have to palpate, particularly the temporalis on the side of the forehead above the ear auricle. Then we have to ask the patient to protrude and try to give a resistance with your fingers if the patient is elicited, and then try to palpate with your thumb and finger the sternocleidomastoid. You'll find if it is painful, that means patient may be suffering with MPDS. For temporalis muscle, we have to palpate on anterior, middle, and posterior tendons and you have to move your fingers and try to elicit the pain. And then intraorally also, you have to keep your index finger on the external oblique ridge and take it around over the ramus in the anterior border, and the patient elicits any pain. That is the region where there is an attachment to the temporalis muscle. Then we have to palpate the masseter muscle in the superior attachment to the zygomatic arches. As we understand, the attachment of the masseter is on the inferior border of the zygomatic arch and at the body of the mandible. So at both these points, we have to palpate the masseter muscle superficially as well as at the lower border of the mandible also. Then we have to do a functional manipulation of the lateral pterygoid. Patient is asked to open the mouth against resistance, or patient is asked to clench the jaw, which might elicit the pain. And we have to be dependent totally on the patient's perception of the pain. Then for medial pterygoid, we have to ask the patient to open the mouth wide open and protrude against the resistance, clench the teeth together, and then you have to palpate on the medial aspect of the mandible intraorally also to see if there is any pain. Regarding sternocleidomastoid, I already mentioned we have to do it bimanually to find out. Then assessment of the deviation of the mandible and the functional movements, we need to ask the patient to open and close and inspect whether there is any trismus or there is hypomobility or hypermobility of the movements of the joint. Then we have to see all the anatomical structures. If there is any limited movements, we should understand. Until unless we know the anatomy of the temporomandibular joint and the facial muscles and muscles of mastication, their attachment, we can't examine them properly and we can't come to a correct diagnosis. And then early opening deviation is, suppose if we ask the patient to open the jaw, and if there is a deviation of the lower jaw, then we must understand there is a spasm of the lateral pterygoid muscle on the side of deviation, and that creates a gradual imbalance due to imbalance of the joint because of the muscle imbalance. Normal lateral excursion of the jaws are up to 10 mm. If there is some restriction, we must understand either there is some joint inflammation, or there may be some muscle dysfunction, or there may be anteriorly displaced disc, which is self-correcting, or sometimes the disc may stuck up, which is called the closed disc. Then regarding the assessment of the clicking, grating, and synchrony of the joint movements, we might use our stethoscope, apply this stethoscope and try to listen to the various joint. Sometimes the click can be felt with your finger, or it may be audible with your stethoscope. Then intraoral examination, we must understand most of the joint problems are attributed to the incorrect occlusion maintenance. Either there is too much of attrition, or there may be some prematurities after the orthodontic treatment, or maybe some prosthetic attachments, maybe a crown or a bridge, or maybe improper assessment of the vertical height of the jaws, or it may be some mobile teeth, it may be some anterior open bite, or most of the time it is attributed to the missing teeth on one side, and the patients tend to eat from one side. So most of the cases I have seen too much of use of unilateral masticatory habits are responsible for the degenerative changes in the opposite joint, or there may be some disc derangements. Then we talk about the MPDS. It is basically a psychophysiological disease that involves the muscles of mastication, which is characterized by dull ache, or sometimes it may be a radiating pain. Acute, it becomes acute during the use of the jaws and mandibular dysfunction also is responsible for limitation of opening. There may be partial trismus, there may be painful joints. The clinical features are there may be some structural dysfunction. The range of the movements in the various excursions are very limited, though there may be no pain at the rest. But when the patient starts opening and closing or using the jaws in various excursion, patient may feel some pain. And then sometimes patient is not being able to chew properly and he complains of muscle weakness. There may be some trigger points at this juncture which are stimulated by macro and micro traumatic episodes. If there is inadvertent occlusal discrepancies are there, patient will have these trigger joints at various points, either at the pre-auricular area or post-auricular area or post-ramal area, or sometimes more commonly at the angle of the jaw. And when you poke these areas with your index finger, there's going to be, the patient is going to elicit a pain, and which is called a jump sign because of the irritation at these trigger points. Sometimes to confirm your diagnosis, we have to give the anesthetic block to the involved nerves. We might have to give auriculotemporal nerve. Sometimes we have to give mesenteric nerve. So if after giving these blocks, if the patient gets relief from the pain, that is the confirmatory test that particular muscle or the part is involved in inadvertent movements of the joint. It may be because of the some problem in the muscle submastications. Then we talk about the radiography. The most common radiograph which we normally do is the OPG, but it hardly gives any information. So in the current times, we have started asking the patient to get the CT scans, which is very useful for looking at the hard tissue structures. But for soft tissue structures, looking at the various muscles, various like retrodiscal area, or if you have to see various ligaments, MRI are the gold standards. And it gives us a very good picture of soft tissues around the TMJ, including the articular disc also. And CBCT is another modality, but personally speaking, for TM joint disorders, I'm not very happy with results of this cone beam CTs. For soft tissues, as I already mentioned, MRI is the best modality where you get to see various structures. This is the posterior attachment to the articular disc. This is the articular disc. This is your superior heads of the lateral pterygoid muscle, inferior head of the lateral pterygoid muscle. It is the mandibular. And then here you see the base of skull. And if there is any discrepancy, if there is any perforation, if there is any, some disc is stuck anywhere, this gives you a very good clue. Particularly MRI are very essential to get the correct clue. Particularly in this case, as you see, articular disc is in favorable condition. And but here you see there is some kind of pathology or roughness you see on the condylar head. It was a case of osteochondroma. With the advent of the real-time or dynamic imaging, it gives us a functional dynamics of temporomandibular disorders. Particularly this dynamic MRI are very, very important in diagnosing internal derangements. Not only internal derangement, but sometimes we'll be able to see the disc displacements also, whether it is with or without reduction, or sometimes if particularly in class 4 cases, when there is a perforation of the discal tissue with this dynamic MRI, we'll be able to diagnose it properly which requires a surgical intervention. We can't do anything with the conservative. So this disc derangement can be classified into stage 1, 2, 3, and 4. Here in the picture A, you see the normal TMJ with posterior band of disc at the 12 o'clock position. This is the posterior band of the disc. This is the anterior band of the disc. And you see the articular disc is absolutely intact with good spacing, inferior space and superior space of the temporomandibular joint apparatus. Then here you see the articular disc. When the patient is opened it up, the articular disc comes exactly at 12 o'clock position at the eminentia, and you can really see a good movements and dynamic MRI. Then in stage 2, when the disease is already started, you'll find the articular disc is stuck anteriorly in closed position. And you'll find at this juncture, the patient's joint movements, they become very painful. And then there is a partial trismus, patient cannot open the mouth fully. And then once we try to open the jaw in this condition, you'll find the disc reduces it is a self-reducing, so it is reduced to a normal position when the same patient has opened the mouth. And then as the TMJ disease progresses on opening, the disc may not reduce, and it is called close problem, where it does not reduce back in position, creating a silent joint. There is no clicking, but the patient is always having a lot of pain while chewing, patient not being able to open the jaw, and result is disc adherence without reduction. Disc gets adhered to the bony tissue. Then we have a case of closed lock, where a displaced disc may eventually become adherent to the articular eminence, limiting the translatory abilities. So patient is not being able to wide open the jaw, and it is called closed lock phenomena. Here, sometime more commonly, the disc always gets stuck in the anterior position, very rarely on a medial or lateral side or posterior side. Then in the stage 4 of degenerative changes, you'll find there is a perforation of the disc. Here you can see there is a perforation of the disc, and there is a bone-to-bone contact with the glenoid fossa of the condylar head, and the patient gets severe pain. There is a perforation which is posterior to the posterior band of the articular disc, and this perforation does not occur throughout the disc, but part of disc is, even if it is perforated, you need to treat these patients surgically, either with disc removal or disc repair. And the friction between these two joint surfaces results in a degenerating joint, which is going to be very painful eventually. So we have been treating TMTs in 3-stage sequence. The stage 1 can be prevented by conservative treatment, that is the pharmacological treatment. Second is which can be treated by minimally invasive procedures like orthocentesis. And third is when there is too much of extension of this disease, which does not respond to these two treatments, then we have to go for surgical management of these temporomandibular disorders. How do we prevent these stage 1 and 2 derangements? First and foremost is the reassurance, which is very, very important for the patient. Psychological instability causes so much of problems for these patients. They always talk about this joint pain. So reassurance to the patient, and because in most of the cases, stress is a prognostic factor, we always advise them to go for some kind of physiotherapy also, some kind of meditation also, along with the muscle relaxants. Then we always advise them to avoid having hard and very hard food stuff, be on soft diet for some time, give little rest to the joint, and we ask them not to talk too much, not to clench the joint, or grinding should be minimal. And we ask them to go for a surface heat therapy, also the ultrasound therapy and TENS therapy by physiotherapist, which definitely gives them relief in stage 1 and 2 type of cases, along with some kind of supportive therapy, as I already mentioned, physical therapy and muscle relaxant. We give some joint lubricants also. In some cases, we might have to give some steroid injection also intra-articularly. So the anti-inflammatory agents which are going to give relief from pain and the reduction of the inflammation are normally aspirins along with the muscle, because in most of the cases you'll find there is muscular spasm also, particularly of the lateral pterygoid muscle. So we give some muscle relaxants also. Sometimes we may have to give some anxiolytic, or in very chronic cases, sometimes we may have to give antidepressants also. As I already mentioned, we have to add to our prescription some centrally acting muscle relaxants like methacarbamol, chlorzoxazone, baclofen, etc., which is to be given 2 to 3 times for 3 to 5 days. Then sometimes in very severe cases, when the patient is not being able to chew anything, intra-articular injections also gives a lot of relief, which are mixed with some kind of 2% lignocaine solution. So while giving, because this hydrocortisone injection gives a lot of burning in the joint, so we have started using triamcinolone acetonide, which is very safe, and we have to inject just 1 ml of solution in the superior compartment of the joint, and patient gets immediate relief. And that relief goes on for 2, 3, 4 months. In the meantime, we give some kinds of sprints, etc., to give the permanent relief to these patients. These steroid also going to reduce the inflammation. In some kind of condylar irregularities, if the condyle has become a little rough, sometimes some agents are used for chemical condylotomy, though we don't advise to give, because these corticosteroids giving again and again may cause some kind of resorption of the condylar head also, which is not recommended at all. So it should be used, steroid should be used selectively. Then we give some anterior positioning appliances. They are ready-made available, or we get it fabricated in the lab. By giving little protrusion to the lower jaw will give a lot of relief to the patient, and patient is asked to wear this appliance round the clock if they can use it, which is going to give them a lot of relief, particularly in type 1 and type 2 types of derangements. When once a condyle has already, or the apparatus already crossed this stage 2, and they are not responding to the conservative treatment, then minimally invasive treatment is available. That is what we call it as the arthrocentesis, where we wash the joints by clearing all the obnoxious material or residual oxidation material which are collected inside the joint cavity. And then at the same time, we introduce some medication like triamcinolone acetonide, which is going to act as the anti-inflammatory. It gives some soothing action. It has some soothing action also. At the same time, it is going to reduce the inflammation in the surrounding soft tissue. These are the landmarks. We draw a line from the tragus to the outer canthus of the eye, which is called Holmund-Helsing line. Then the point which we have to draw from this tragus to 10 millimeter and 2 millimeter down this line, we have to mark 1 point, and 10 millimeter further, we have to draw a second point, and around 10 millimeter down there, we have to draw a second point. So one needle is introduced here, the another one is introduced here. So we give either saline, or we give the ringer lactate solution to wash these joints. And so from one needle, the solution is introduced, and from the other needle, it comes out like a spray. So just to confirm whether you are in the right place in the superior compartment, you have to give little joint, and then we use about 250 to 500 ml of solution to wash these joints. And nowadays we have started using a single needle also. And with the advent of the technology, this arthrosynthesis is done by the orthoscope also nowadays, which gives us the internal picture of the joint also. Then in stage 4, once we have already come across this discal perforation, which is very much visible in MRI, these degenerative joint diseases are managed by open joint procedures, surgical interventions like condylar shaving, disc repair, disc praxy, etc. This was a case of condylar shaving. This girl has undergone a long orthodontic treatment, and she came to us with internal derangement of the joint. And when we took her MRI, we found there was a perforation in the disc. And what we did, we removed the disc and we did the condylar shave, and then we interposed the glenoid fossa and the condyle with temporalis muscle sling to interposition this. And this temporalis muscle interposition is going to lubricate the joint also. And then that is how we could treat this girl. And the opening was also became good. If you compare this joint and this joint, you'll find a lot of difference. There was a lot of gritting and grating. There was resorption of the condylar head, and there was a damage to the disc. Here you can see the perforation in the disc. Normally, this kind of incision we have to take, a priorical extended incision to open up the joint, and then removing the disc, and then interpositioning of the condylar shaving and interposition of the temporalis muscle, which comes from the medial aspect of the zygomatic arch to cover the glenoid fossa and the condylar head. This was the post-op. She achieved around 40 mm of opening without any pain. Then we have the new postulation or new inventions in our field of temporomandibular joint disease management, where we can see the joint, we can lubricate the joint, and surgically, if the damage is too much, we can do the total joint replacement also. And also, if we look into the future, to develop the new joint with the stem cell therapy. With arthroscope, we can literally see the joint inside, and though there's very limited literature is available because not many people they are using all over the globe, but I'm proud to say in India, at least 5 to 6 centers, including our center, we have started using these arthroscopic procedures. And it gives a absolutely live view of your internal view of the TM joint area. And we don't have to be dependent on any blind procedure, which we used to do in orthosynthesis. So uses of arthroscopy is a very good tool for diagnosis. Then you can do the lavage of the joint or orthosynthesis. We can do the lysis of the joint because there are a lot of adhesions which are formed because of the degenerative changes. And we can always do some procedures like eminectomies, particularly in cases of dislocations, condylar shaving in case of condyle resorption, discectomy can be performed with these orthoscopes, which is minimally invasive two-hole surgery. At the same time, lubricating joint, again, is a chairside procedure. As we all know, one of the constituent of our synovial fluid is the hyaluronic acid. So in degenerative changes where there's a lot of clicking or gritting of the joint, we have started giving this injections of hyaluronic acid, which imparts a viscoelastic character to the joint. And then the joint becomes very smooth running and it becomes absolutely painless. The major cause of breakdown of the joint lubrication is the overloading. As you all know, hyaluronic acid itself is a viscous component, and when we inject, it is going to be a little painful. So we always inject the your xylocaine 2% initially, so that when we inject this hyaluronic acid, which is a viscous component of the solution, it is going to improve the lubrication without any pain. Then in damaged joints, particularly where you find there is a complete resorption of the joint, there are cases where they come, particularly in elderly cases, because of the osteoarthritis, we need to replace the joint. As orthopedic people, they have started replacing the total joint in knee and hips. It's basically, the intention is to restore the form and function of the joint, particularly in very severely damaged joint, particularly when the disease reaches to the end stage where nothing else is required, but then you have to do the condylectomy of these cases. This is a case of total joint replacement where we have to remove all the obstruction in the glenoid cavity. We have to use a special burr to make it straight. And this is the HDP glenoid fossa, which is fixed with the screws. And here is the joint. Here is the joint. So this is the post-op X-ray, and this patient started work when he had a good. Basically, this was a case of temporomandibular joint ankylosis, which was opened up some few years back, and then this particular patient is being replaced. And in the second stage, we corrected this deformity also of the division of the chin also by doing genioplasty. Then when we talk about the future, I'm quite sure the stem cells are going to be very useful for generation of the new joint or repairing the damaged joint by innovative scaffolds, and they are introducing some morphogenic biological proteins. These scaffold-based tissue engineered scaffolds are going to be useful. The orthopedic people, they have already started trying on it. Still, the day is not far when the maxillofacial surgeons are also going to start using these ceramic scaffold or polymer matrix scaffold for joint repair. When we talk about various disorders, apart from the internal joint, internal derangement of the temporomandibular joint, then we come across some of the cases. In majority of the cases, you'll find hypermobility of the joint, where the condyle is going to move across the apex of the condyle. But these cases are asymptomatic and they need no treatment. It may be because for some or other reason, or maybe little more pressure on the joints, there may be some resorption of the glenoid fossa and your condylar head, but this requires no treatment, basically. Or sometimes, if it is painful, then we give some Cousin-Zen's buttons, applying some elastics so that to restrict the joint movements, and there's a formation of the new tissue when we give the rest to the joint. Then TMJ dislocations, which is our two types. One is subluxation, where the jaw will lock in wide open position, but it can be self-reduced by the patient with various degree of efforts. And this point of time, sometimes they may be painful, they may not be painful. But in dislocation, patient is unable to self-reduce these joints. This is very common in elderly people, where the condyle has gone beyond the eminentia articularis and they come with the open mouth. Sometimes there is so much of spasm. If you try to reduce them, you're not being able to do so unless you sedate these patients, give some local injection, or sometimes in very chronic cases, we have to take up these patients under general anesthesia also for correcting these dislocations. The dislocations may be classified, which are based on the pain, hypermobility, hypomobility, or there may be some people, they are habitually dislocate their joints. I don't know what pleasure they find in that, and they try to reduce it. Then TM joint dislocation are classified also on the basis of the duration. Sometimes there is acute dislocation while yawning or eating something very big thing like pani puri and all. The patient's joints are stuck. And then there are chronic dislocations, particularly the patients, those who are very thin, lean and thin. They try to open and they dislocate their joints. So it is very painful, particularly they are unable to close their mouth. They are very, very apprehensive also. And then there's the muscles of mastication, they go into spasm. And you'll find in the preauricular region, because the dislocation of the condyle, you'll find a hollowness in the preauricular area. Basically, the problem area is we do manage these conservatively, particularly in acute dislocation. We always have to reassure the patient. We have to relax with tranquilizer or some kind of sedative. We have to relieve the pressure and massage to the area and reposition these joints with manipulation. It is possible in acute condition or the recent dislocation. So we have to manipulate either under local anesthesia. If not possible, either we sedate the patients, giving some muscle relaxants like propofol, etc. And sometimes we have to manipulate under GA also. And then we have to tie up these joints, these mouths, to at least for 48 to sometimes 72 hours. Otherwise, as soon as we open up, because of the muscular spasm, the patient tend to open it, and then the joint, they dislocate again. So the classic technique we all know, we have to stand in front of the patient, thumb on the patient's inferior molar bilaterally, always up your thumb so that when the patient is closing, after the reduction of this dislocated joint, they should not chew over your fingers or thumb. And we always have to push the joint downwards and backwards, and suddenly you'll find with a click joint, you'll find mouth is closed and your dislocated joint is reduced. Then sometimes we do it in recumbent position also. The patient is lying down and operator has to stand behind the head of the patient, thumb placed on the inferior molar, again downwards and backward pressure is responsible for correction. Post-operatively, we have to give a Barton bandage. We have to immobilize these mouths for 10 to 14 days. We have to keep them on semi-solid diet, and then we have to give some NSAIDs along with the muscle relaxants for 3 to 4 days. And then sometimes in chronic cases, we may have to take up these patients for surgical interactions, surgical management, where we have to do either eminectomy or sometimes we have to do the partial cornelectomy, etc., to correct the dislocation. So the take-home message is all these temporomandibular joint problems are manageable on OPD basis, majority of them. Correct diagnosis is the key. Conservative management is effective, and 80% of cases, only 3 to 4%, they need the surgical intervention. Counseling of the patient, physiotherapy, meditation are the additional ways to give the positive response to our treatment, though it may take time. Always make it a multidisciplinary affair. Treatment lies in the basic dental practice. A high filling, impacted molars, malocclusion, etc., are the causative factor for these temporomandibular joint disorders, particularly internal derangements. We always have to find out the causes inside the mouth of our patients. With these words, if you have any doubts, you're most welcome to ask me questions. Thank you.
Thank you so much, sir. Thank you so much for such a valuable session on TMD and its management. I know it's a very vast topic that you have covered in a very compact time. Thank you so much for that session, sir. Now I would like to request Dr. Hari, sir, if any questions, please, all the questions are welcome. I'd request our panelist, Dr. Hari, sir.
Hi, good evening, one and all.
Good evening, sir.
I'm very
Good
happy
evening,
to
sir.
participate as a panelist. Good evening, Dr. Rajesh Dirwani, sir. I have met you a very long time before. You are a very senior oral surgeon from Mumbai. Right. And Nitin, I am supposed to ask the questions or?
We have, yes, sir.
You
If have
can
any
ask me the questions,
please,
or you can add upon something if you have something more to say on this topic. There are a lot of things to
valuable
that we
inputs
can.
are also welcome, sir.
Yeah.
Right. Okay. Probably I'll just give my comments. Then probably you can interact the Q&A. Is that okay?
Sure, sir. Sure.
Right. Okay. I thank Dr. Rajesh Dirwani for giving a wonderful lecture on TM joint related diseases, right from basics to the advanced management. Yeah. And it's very commonly seen in our general dental practice. People most of the time forget to examine TM joint whenever patient reports for a dental checkup or any other dental treatment. So it's very vital to examine the TM joint because that's the only joint we have in our region or in our domain. And when you examine on regular checkup, you see a lot of clicking, soft clicking or hard click or painful clicking or painless clicking present, which the patient is not aware of. Yeah. So it's very important if we diagnose such symptoms early and we can advise the patient accordingly to avoid further wear and tear of the joints. Yeah. That is one thing I would like to inform. With general dentists have to keep a note always in their history taking on TM joint. And Dr. Dirwani has nicely said how you basically examine the joints and what symptoms you have to look out for. And you look out for the etiological causes as well. Yeah. The first TM joint arthroscopy I learned was from Dr. David Frost from North Carolina. I learned it in 1994 from him. And it was a pleasure. At that time, I think arthroscopy has not entered India. But
Right.
we enjoyed doing a lot of arthroscopic work, and he used to do a lot of disc repair as well. And then later in my UK job in 1999 in Worcester Royal Infirmary, we were doing a lot of TM joint arthroscopy. And in Stoke-on-Trent, we did a lot of total joint replacement with Dr. Timothy Malins, because we are a very active surgical department. And TM joint on its own, as we see, it's a separate subspecialty in oral surgery. There are many oral surgery departments in the US run fellowship in TM joint and occlusion. That is the importance of TM joint. And as rightly said by the speaker, it's very psychologically oriented joint as well. Yeah? And many times people are stressed much, they turn out to be having pain in the TM joint. And in UK, we always ask the history of stress whenever a TMD patient comes on myofascial pain dysfunction syndrome. And it's surprising, many times the patients say they are stressed because they lost their job or they are moving their home or they had some other family issues. And I remember my boss, Dr. D.S. Gupta ji in Lucknow, was the head of orthodontic department during my residency program. I remember he was saying in Detroit during his MS orthodontic program, they were attending a TM joint 1 week workshop, and half of the participants developed TM joint pain 3 or 4 days through the workshop, which is they started thinking so much on the TM joint anatomy and functioning. So it's such a psychologically oriented joint. And one of the other classic history is like whenever patient has got a dentoalveolar surgery under general anesthesia, the mouth opening is usually done a little bit wider during the general anesthetic session because we don't need patient cooperation. And the next day, typically the patient complains of some TM joint pain because of the overstretching of the TM joints and the mouth opening. And always I ask history whenever the patient comes with some TM joint pain, whether they had a wide opening incidence, and they always give many times a history of going to the McDonald's and having a Big Mac, the double burger wide open and eat it, you get injured your TM joint strained as well. So anyway, there's so much of history we can take in right from our habits, stress, and then the malocclusion and other occlusal interferences present in the mouth. But it's very critical to diagnose and note it down so that we can cut down the progress of TM joint problems at a very early stage in general dental practice. Yeah. And interestingly, regarding the stem cell and tissue engineering, because I am involved in a lot of scaffold research work, I think it's quite a bit a long way, but still, I think we have a lot of hopes. Probably a joint can be organoids sort of scaffolds can be developed, and hopefully joints can come out in future where we can implant or do total joint replacement with a developed biological anatomical joint than a 3D printed titanium joint or whatever we do now. Yeah. So it's a comprehensive coverage. The speaker has covered everything which is to be noted down for general dentists. And I'm very happy to be invited as a panelist to give my comments. And thank you one and all. And seasonal greetings for this April 14th, Samoa Festival Day throughout the country in each region. And thank you, Dr. Rajesh Dirwani and Dr. D.N. Kapoor, sir, for inviting me. And Nitin, I could be happy if you could coordinate the Q&As. I think there is one question I can see in the chat or something.
Yes, sir. We will take audience questions in the end section for sure.
Yeah.
Sure. Thank you so much, sir. Thank you so much for such a good note. Now, I would like to request Dr. Rajkumar, sir, also to share his experiences on the topic. I would like to request Dr. B. Rajkumar, sir, to please share his valuable inputs and share his experience on the topic of TMD and its management. I think sir is not available due to some technical glitch. So we have one of the questions from our
Dr. Nitin, sorry to interrupt you. Sir is there, but sir is just on mute.
Okay. If Dr. Rajkumar sir can hear us, can you unmute, sir?
Hello.
Hello. Good evening, sir.
Yeah. I'm here.
Yes, sir.
Yeah. Sir, it has been not much of oral surgery into the connect, which I am there. But again, today TMD has been made a vast, lot of things has been found out because of TMD disorders. There has been a lot of problems which we are going in a normal practice. And we as a general practitioners, there has been a lot has to be said to it because there is a lot of difficulties which every patient comes with it and then we are unable to trace it out. I think that we should arrange in such a way that most of the general practitioners have been told about it. And if we could correct the TMD problems, we could come out of a lot of things which are unable to diagnose it. And I think whatever doctor has said that it has been an excellent issue. And since I have not much of questions to ask him, I would leave it to the other panelists to talk about it.
Thank you, sir. Thank you for your kind words, sir.
Yeah.
Rajesh, sir, we have one question from Dr. Pooja Khanna that she had one patient who had a normal mouth opening before the patient underwent an implant surgery. And from the next day onwards, the patient had significantly reduced mouth opening. Is it a case of hyperextensibility or a trauma? And what would be the treatment modality for the same? Over to you, Rajesh.
Yeah, basically we have to just find out what kind of, why the person had the partial trismus. What I could understand, in one day you can't damage the joint. or maybe person cannot get MPDS also, which may be responsible for this. To my mind, probably it may be just a traumatic injection to some of the tendon of the muscles of mastication, particularly if it was a mandibular implant, probably while giving the mandibular nerve block, either the needle which has traumatized the tendon present there, or maybe sometimes due to improper aseptic precaution, sometimes we may inject an infected solution which may be responsible for this partial trismus and the pain. Or if it was a upper one, then of course we give some infiltration, or sometimes we give posterior alveolar nerve block, which may cause damage to some tendons of the temporalis muscle, which just passes through that area only. So to my mind, it may not be a case of true TMD. It may be something else. I think Pooja will be able to tell us exactly what must have happened, because if the joint was painful, it may not be the joint, but the muscle, because of the traumatic injection, or maybe some local infection there.
Good evening, sir.
Yes.
Actually, this patient was referred to me, and it's not my patient. And then this is what the history patient gave, that she went, she had this implant surgery a day before, and afterwards the mouth opening is reduced. So it was reduced to such an extent that, I really couldn't open the mouth and see. So I only suggested a muscle relaxant for the same.
So which implant was done? Which area?
It was mandibular only.
Mandibular molar?
Yes.
Okay.
So probably I was saying it could be the, injection itself.
Injection itself, yes. And then it goes for pretty long time. Sometimes the patient, we have to really give them the Brisman's movements with your mouth gag, and when we try to open it up, you'll find an absolute clicking type of sounds, and then patient suddenly opens it up, though it is very painful. So I think it is the muscular spasm because of the injection, or maybe solution.
Okay. So this will be handled with medicines only and with a mouth gag, as you are saying.
How much is the pain now?
Pain is still there while opening only.
Right. And how many days have passed already?
It's been like 2.5 weeks.
Okay. What I'll suggest you is go for muscle relaxants. In the local area, palpate, and if you find some pain, give some local injection. And try to use it with your stretcher, mouth stretcher.
Okay.
Keep the mouth stretcher on the opposite side. And then patient may have pain, if it is very much painful, then you can give some sedation, or you can take this patient in a short anesthesia like propofol and all, where anesthetist is required. So you can open it up. And I'm sure it will open up and it will not close again. But then you have to give the movements of the jaws for a week or 10 days, along with the muscle relaxants.
Okay, sir. Thank you.
Any more questions from the audience are welcomed.
Another question.
Yes,
may I
ma'am.
ask? Sir, do you use splints regularly for your TMD patients?
Yes, I do. In fact, particularly, as I told you, stage 1 and 2 cases, sprints are very useful, definitely.
Okay.
Dr. Rajesh, what is your prescription for retrographic mandible with class 2 division 2 type of malocclusion, where mouth opening is limited because of deep bite, and much problem is encountered in TMJ joint?
Right, sir. Here also, sir, if there's a pain, we have to first of all do some radiological investigation like CT or if required MRI and see the cause of the reason why there's a pain or why there is a restriction of the jaw. And then start with the conservative treatment, maybe arthrocentesis is I feel it gives a good result. But in majority of the cases, if the degeneration has already occurred in the joint, arthrocentesis will also give the relief for only 3 to 4 months. Then again, patient will come back to you. So correction of the defect is very, very essential, sir. And for retrognathic mandible, if it is a skeletal deformity, I would like to definitely advance the jaw surgically. And of course, with orthodontist help to maintain the proper occlusion, correction of the deep bite, etc. Pre-surgical orthodontics followed by surgical intervention.
Okay. Anybody else want to ask any question?
Yes, sir. Rajesh sir, when we had one our patient, she was an air hostess, 20-year-old girl, and she used to complain of a locked jaw whenever she was on board. So limited mouth opening. We put her on splint also and muscle relaxants also, but no response. Clicking was present.
Mm-hmm.
So what can be our treatment protocol for the next sessions?
Clicking in, and was it painful?
Painful, sir. Popping sounds were present, clicking was present.
Right. But then most of the time she used to get this only in air or on the ground?
Only on the
also?
high altitude, yes, sir.
Yeah, that's really surprising. If a person has to have this kind of symptoms, it should be the similar on the ground or in air. Air getting any problems with the joint is very unheard of, and it is not given in the literature also. But the treatment protocol will be for such cases, first of all, conservative treatment. For the correction of the click, as I already mentioned, first of all, restriction of the joint movement. So we give some orthodontic brackets we put on the molars and a premolar, and they give them light elastics just to restrict the jaw movements. And keeping them for 3 to 4 weeks, patient does get a lot of relief because the restricted joint movements. Ask these patients to be on soft diet, not to talk too much, and not to open the mouth too much. 2-3 weeks relaxation to the joint will do good to the joints. As far as clicking is concerned, clicking can be corrected. In very severe cases where there is a gritting or clicking, most of the time, it is because of the disc, the post-discal tissue, it becomes a little loose. So in such cases, we have started giving, to tighten it up, we give whole blood injections also. We give hyaluronidase injections also, just to lubricate the joint. And basically now the people, they have started a couple of, in the literature I have seen, people, they have injected some PRP also, platelet-rich plasma. That has given relief. And click, majority of the time it will go with the restricted joint movements. And then you have to respect to the joint, not to eat something hard, not to open your mouth too wide. And I found that in 3 to 4 weeks time, the joint is repaired. I mean, that is repaired. In very, very chronic cases, sometimes we have to do the discopraxy, where the loosening of the tissue can be tightened up, but it is an open surgery. Or if you're an expert, then you can do it arthroscopically also.
Okay. Thank you so much, sir. Thank you, sir. Any more questions if you have? So now I would like to request Dr. D.N. Kapoor, sir, to please thank our speaker of the day for such a wonderful session. Dr. Kapoor, sir, you're on mute, sir. Can you unmute yourself? Yes, sir. Good to go.
I'm really thankful to Dr. Rajesh Jidwani for accepting our invitation in
Thank
such
you,
a
sir.
short
Thank you.
notice
Thank you very
and
much.
giving a wonderful presentation, opening the horizon for many of the dental surgeons practicing and encountering the problem of temporomandibular joint dysfunction or TMJ dysfunction disorders and many types of various problems. I'm sure they'll be benefited in larger interest. It was very good presentation. I thank once again for
Thank
coming
you, sir.
and giving a very
Thank you, sir, for
valuable.
kind invitation, and thank you for giving me such an opportunity. Thank you, sir. Very kind of you.
Dr. Anmol.
Thank you, sir. Now we would like to request Dr. Chitre, sir, to please enlighten with with some wisdom words.
Dr. Chitre.
I think sir is not there with us due to some technical reasons. I would request Dr. Anmol to kindly address the gathering. Dr. Anmol, you are on mute. Can you unmute yourself? So moving forward, I would like to request meanwhile Dr. Ashish sir to please have a word of thanks and conclude our 2 webinars for the day.
Thank you, Dr. Nitin. Very good evening, everyone. It was a very nice lectures today. I would like to thank certain speakers of today's webinar series. Dr. Rajesh Dherwani, sir. It was a very nice lecture on temporomandibular joint disorder, sir. It was a very informative, in-depth lecture. This knowledge will surely help the practitioners in their daily practice. Thank you, sir. Thanks a lot. I would like to especially thank Dr. D.N. Kapoor, sir, and Dr. Anmol Bagaria for putting their efforts in starting and organizing these types of webinar series, which will surely increase the knowledge of the practitioners as well as the students. And they will get to learn about the advancements of the various fields. I would like to thank Dr. Mahesh Verma, sir, Dr. Mahendra Azad, sir, Dr. Rajiv Lal, sir, Dr. V.S. Kohli, sir, Dr. Y.K. Virmani, sir, Dr. Sarvaraj Kohli, sir. A special thanks to our chief panelists of today's webinars, Dr. Shadab Mohammed, sir. And I would like to specially thank our today's master of ceremony, Dr. Nitin Garg and Dr. Misbah Qadri. And at last, I would like to conclude with, I would like to thank all the dear delegates for joining us and increasing their knowledge. Thanks a lot. Thank you, everyone.
So thank you everyone for attending our 2 webinars of the day. Thank you so much. Thank you, sir. Thank you. Have a wonderful night. Good night. Thank you.